I think that a lot of men are very fixated that testosterone is going to fix all their erections. They have erectile dysfunction or they're not as strong as they used to be, and testosterone is going to fix it. And you and I can both agree, and I say this all the time, that really isolated hormonal problems are like 6% of the population that have ED. But what percentage of men do you see that notice like that they're completely, in your practice, they're completely cured with testosterone?
It all depends on certain baseline demographics. So I just want to give you an example. So there was a large trial called the T trial. The T trial came out in New England Journal of Medicine. This was 2016, showing that men who had low testosterone levels, when you put them on testosterone, had an improvement in erections and they had improvements in sexual function. And then came the Traverse trial. And the Traverse trial came out showing, this is 5,200 patients, but the subset study was 1,100 men, sexual function, randomized placebo, and they looked at increase in sexual performance or activity and IIEF, meaning erections. In that trial, men had an improvement in sexual activity, but they did not have an improvement in erectile function. So which patients tend to benefit the most? I think it's patients who do not have a significant amount of comorbid conditions, right? Because if you have significant diabetes, obesity, it's hard for me to imagine that I just give you testosterone and the whole world is cured.
Right.
It helps. The second component of the patients is whoever starts very low. The lower you're starting, the greater the improvement, right? And we've seen that, and Dr. Corona has shown that as well, where the greater the delta, the greater the improvement. So patients with not so many comorbidities, I think mild ED, and the lower the T levels, tend to do better as monotherapy. Now let's hold this thought, because we're talking about giving T as just a simple drug to help with ED. In 2018, when we wrote the guidelines for ED, testosterone is not a treatment option for erectile dysfunction.
But it's recommended to check it.
To check it. So that's a great point. So you would say, why are you checking it if it's not a recommended treatment? And the reason we put that in there was because data would support that PD5 inhibitors like Viagra, Levitra, Cialis are more effective when you give a man testosterone in combination if they're hypogonadal. So the best example is a man comes in, his levels of testosterone are 200. He says, my Viagra is no longer working. You say, okay, Mr. Smith, let me put you on testosterone. And then you raise his level to 600, and 30 to 50% of those men will say, my Viagra is now working, right? So it basically takes PD5 non-responders and makes them responders, right? And so combination therapy makes sense. But I do think monotherapy in a select population of patients, not so many comorbid conditions, very low T levels, probably younger, mild ED, they actually do better than most in raising those natural, improving their erections.
Yeah. Well, the T trials were an older population,
Yes.
right? 65 and above?
and older.
Right.
Right.
Yeah. And the Traverse trials was 55 and above?
Yeah, so 45.
45.
Yeah,
Okay.
so you have a group of patients who were above 65 and below 65. And what was not fair about the Traverse trial was that 12% of the patients in the trial for the sexual function didn't have a sexual partner. So how are you going to know on your II? You don't even have a sexual partner.
Yeah,
Then,
your IF zero.
Zero. And on the Traverse trial, remember, in order to get into our trial, you had to be really sick. You had to have increased cardiovascular disease or at least three of the 8 cardiovascular risk factors, right? 50% of those patients had cardiovascular disease and they had diabetes, hypertension. They were a sick population of patients. And so now you have a sick population of patients who may not be even interested in having sex because they don't have a partner. And so you're going to tell me that they're going to have a significant improvement in their erectile function. One of the other problems with the Traverse trial that brought up was that our definition of normal was above 350. 350 to 750, right?
Yeah.
Now, that was a trough number, but it still was at 350, so it's kind of hard to say where they exactly were. But some were criticizing and saying, look, if your number comes in at 370, you're telling me that's normal? You know, if you look at other trials like the T4DM, which was given with Nabita, which is a long-acting injectable, those levels were in the thousands, and we see different kind of results with those. But some would say, I don't know if your levels were high enough in the Traverse trial to really make a difference. So that may be just another confounder.
The other thing in the Traverse trial was you studied gel, right? Androgel.
Right.
And then that, I think I heard people sort of criticizing, well, you don't know if that's the same for injectables or you don't know if that's the same for other formulations.
Kind of. Yeah, I agree. So there were 7 trials in the Traverse trial. And if you look at safety, 2 of them were safety. One was cardiovascular, one was prostate. In terms of prostate, I believe in something called the prostate saturation model. And we've shown that it's roughly around 250. So if a man is below 250 and you raise his testosterone level, PSA will go up. you'll start seeing a slight increase in prostate volume. We do, but then it plateaus.
Yeah.
Right. So if you take someone who's under 250 and I put them on gel and put them above 350 or 400, it's not going to change much if I take them to 800 in terms of prostate safety.
Right.
I think cardiovascular is a little bit different, because the higher the T level, as we mentioned earlier, the higher rate of erythrocytosis, the higher rate of potentially hypertension. And so I'm not sure if it's completely translatable from a gel to an injectable. And not completely for cardiovascular risk. And so I think that's something to keep in mind. The other findings that we found, there were two statistically findings. Atrial fib, 1% was increased. Chronic renal insufficiency, 1%. 1% were not adjudicated, but I have to admit that they were there, so we acknowledge that.
Sure.
And then pulmonary embolism comes up quite a bit, but it wasn't an endpoint, and it wasn't statistically significant. It essentially was 0.5% versus 0.9% difference in those men being treated with testosterone versus placebo. So people kind of bring it up, but I say it wasn't an endpoint and it wasn't actually statistically significant.
So do you think, obviously based on the TRAVERSE trial, I think we feel a lot more comfortable with testosterone, but do you think that, for example, injectables, based on the totality of the data, that there's a concern for cardiovascular disease with testosterone replacement?
I think that before even the TRAVERSE trial, there were only 4 studies coming out suggesting that there was an increased risk. And those studies were poorly designed, 3 retrospective, 1 no control group, suggesting that there was some mild increased risk. The majority of studies have shown no significant increased risk. And there's 200 plus studies suggesting no significant increased risk. I firmly believe that a man with low testosterone is at an increased risk of cardiovascular events, an increased risk. And so I think there is more detriment to leaving that patient low than raising his levels to the normal range, even with an injectable.
And then in terms of, we didn't touch on this, but there's obviously conservative lifestyle changes you can do to improve your testosterone. So one, what are those? And then what sort of increase can you see with just conservative treatments?
Yeah, so the problem with lifestyle modification is that each one individually offers just a small amount. Okay, so there's one study looking at diet and exercise. One study showed there was a 25 nanogram per deciliter significant increase, but it was statistically significant, but you and I know that 25 is not going to cut it. And some studies will show up to 100. Okay, fair. Good, but not going to change the needle too much. But now about obesity. Now, obesity is probably my most important lifestyle modification, because there's such a strong bidirectional relationship between obesity and testosterone levels. If a man loses 10% of his body weight, his testosterone goes up by about 85 nanogram per deciliter. But if he loses 15% of his body weight, it goes up to 250 nanogram per deciliter.
That's a lot.
And it's a lot. And the best data is in the bariatric literature, where they do bariatric surgery, they lose 15% of the body weight, and they really gain a lot of T. Now, with the GLP-1s, that's actually changed the paradigm too. Because when these patients are losing a significant amount of weight, now they can actually keep the weight off and their T levels go up. Because before, when they used to lose 10 to 15% of their body weight, most of the time, they gained it back.
Right.
So then what are we doing? So that's important. So GLP-1s has helped quite a bit. And so I think weight loss is important. Sleep apnea. So some studies have shown, that if you improve the sleep apnea, you can increase it by 100 nanogram per deciliter. Varicocele repair, anywhere from 85 to 95 nanogram per deciliter can improve as well. So if you add it up, I sleep apnea, lose the weight, I do some exercise, you add it up, then you'll notice that there may be some benefit. Stress also and sleep. So if you mitigate your sleep, if you reduce your sleep, you can see significant 10 to 15% decline in serum testosterone levels. But the second half of the night is more important than the first. So let's say you went to bed from midnight to 8 a.m. and I didn't bother you from 4 a.m. to 8 a.m., you don't see much of a decline, right? But let's say you slept great from 4 a.m. to midnight to 4 a.m. and I started getting some phone calls at 5 and 6 a.m., you start seeing the decline. So that second half of the night is more important. So all of these things are additive, right? All of these are additive, and I think that if you do these and you can change your lifestyle modification, you can actually see a sustained, significant increase in serum testosterone.
And the stress literature is tough. I mean, there's literature on residents, I think it was one study on male residents and other high stress occupations, but it's very difficult to study stress.
It's very difficult, but I was just invited to give a lecture at SOCOM. This is the military, the Navy SEALs and the Rangers, and there is it's a condition that's been out for a while called operator syndrome. And what the military is noticing is that when you go through military training and then you go through something like Hell Week, the testosterone levels significantly decline, right? Cortisol levels go up, and these patients, these soldiers, even after the training is over, see a sustained decline in serum testosterone levels several weeks after stopping. So it's called operator syndrome. The stress on the body can significantly reduce the testosterone in men and women, right? In men and women. So the question is, what should we do? So if you look at two soldiers in the military, and one has a level of 320, which is normal, and the other one has a level of 800, right? Clearly the one with 800 has a significant advantage than the one with 320. And unfortunately, at 320, you can't treat because it doesn't meet the guidelines. The military uses the AUA guidelines of 300, right? So just from a combat military point of view, should we consider doing things to raise the testosterone level in men who are low normal, just to give them
a safe way.
in a safe way to give them an advantage? Because I think cognition, muscle mass, bone mineral density. I mean, I can go on and on about the beneficial effects of testosterone. And if you have someone in the battlefield, I want them to have every advantage they can have in order to be successful.
But you could extrapolate that. So you and I know this from urology, like you have to treat kidney stones in pilots, for example, because you don't want someone flying a plane and having an issue with a kidney stone. But like someone flying a plane, someone operating on you, someone taking care of your life, with your life in their hands, should they be optimized?
I think they should be optimized, right? And the reality is, I think that everyone should be optimized.
I agree.
Like, everyone should be optimized. There's something to say about improving your quality of life. Now, every time we talk about testosterone, we talk about libido and energy and sex drive, but let's talk about the real deal here. There are 5 things that can happen if your testosterone is low, and these are pretty significant. You're at a significant increase in having a heart attack, which we talked about. Significant increase in osteopenia and osteoporosis, right? Significant increase in depression was one of our papers. Low T significantly reduces depression in patients, right? It is associated with prostate cancer. I'm not saying it causes it, but we know that men with lower T levels are more likely to have prostate cancer. That's very important. And we also know it's associated with diabetes and obesity. If you give someone Lupron shot, in 3 months, you will see them go hemoglobin A1C rise significantly. We see this. So diabetes, obesity, metabolic syndrome, depression, prostate cancer, cardiovascular risk, bone fracture. You show me one other blood test that you can order today that would be more indicative of a man's overall health. It's not his hemoglobin A1C. It's not his thyroid. Give me one blood test, one.
That does all those things.
That shows me more indicative of a window of his overall health. That testosterone is the best barometer of a man's overall health. Right? It's the best barometer. The second question should be asked, well, if I give you testosterone, will I improve those 5 things you mentioned? Right? I mean, that's another topic. And that's where it starts getting a little bit controversial, because we do know that if I give you T, you will increase your bone mineral density. You can, but does that decrease bone fractures? Not have been shown yet, but I think we need more data, right? If I give you T, will that help with cardiovascular disease? Some people believe yes. I believe yes, but we need more data, right? We do know that giving T does help with obesity, and we do know that giving T actually helps with diabetes. That was a T4DM trial. Right? 13% reduction in diabetes in those men taking T. So that's been shown well. And you look at prostate cancer now, there's this concept called BAT, bipolar androgen therapy. How do we treat men with metastatic prostate cancer? If you walked into Johns Hopkins today, they give you high doses of testosterone to treat your metastatic prostate cancer. Bipolar androgen therapy would have been unheard of like 30 years ago. But that's how we're treating them. And in the first study that came out in 2015 was a 50% reduction in PSA, 50% reduction in metastatic disease. Later on, they did the Transformer trial, also showing that there's increase in overall survival, or no difference in survival with testosterone with enzalutamide.
In terms of, the one thing I think that's still the unquestionable, right? These people between, let's say, 300 and 450. And if you treat those people, are you still going to see those same benefits?
So the thing is, you don't see as much, right? So there have been studies looking at men who are above 300 and below 300. And those men who are in the eugonadal range don't tend to see the benefits than those in the hypogonadal range. Now, some do, because I still believe we all don't have one number. So in that 300 at the 450, there may be people who are below their set point, right? But the higher you get, the more likely you are to cover everybody. Right? So it makes sense that if it's at 200, most people are not saturated, and so they're going to see a benefit. As you get to 400, most people are going to be, instead they're going to see. So as we get higher, it's less likely to see benefit.
And then what's the range that you use for free testosterone in terms of when do you feel like that's saturated versus not?
Yeah, so free testosterone typically is 50 to 250 picogram per milliliter. That's the range.
Yes.
I typically like to keep the patients around 200, you know, just in the upper normal. I always like to pick the upper quartile of normal,
Yeah.
right? You look at your range, upper quartile of normal typically is where I think most people do well. There's no harm in putting someone in the upper quartile of normal. And if you do, you're probably saturating most people, so
Yeah.
you're not having to titrate more over and over again.
Yeah.
So that's typically the range that I use.
Yeah. And I think it's interesting because some of the reference ranges will come back at like 60 is normal, 50 is normal. And actually, isn't it like fifth percentile is 75?
Yes, that's right.
Yeah.
That's exactly right.
So-
but we're still fixated on the why. I mean, if I start someone at 70, if he's a 70 free, could he benefit? Yeah, he still could benefit.
Right.
Right? He still could benefit.
Yeah.
So I don't get so fixated on the numbers. Even when I treat women, it's a symptomatic disease.
Absolutely.
I'll give you an example. Like, you know, if you look at women in the United States and we treat women who are postmenopausal, they come into your office, she's 55 years old, and she says, "Doctor, I have hot flashes and they're very severe and I'm just not feeling well." The standard of care in the United States is to give her estrogen. And if she has a uterus, you give her progesterone with it. Fair enough. We don't check the level. The standard
Right.
of care is not to check the level. The standard of care is to give her the medication, and she's on her way. Then she comes back a month later and she says, "I'm feeling better, but I'm only 50% better. I still have the problem." What do we do next? We up the dose on the estrogen without checking the level
Right.
until she feels better.
Yes.
Right? That's the standard of care. But with testosterone, it is like a crime if you don't check the level and make sure that, I mean, so there's a little bit of differences here, but I think
Yeah.
this is a symptomatic disease and we should be more driven on symptoms.
I agree with you. I agree with you 100%.
Yeah.
In terms of, you mentioned earlier varicocele repair.
Yes.
So varicoceles can range from being symptomatic to not symptomatic, and sometimes they're not symptomatic. In those patients, and a varicocele is essentially enlargement of the vessels in the scrotum that surround the blood vessels that go into the testicle, which can create changes in the environment, right? And so in those patients who don't have symptoms, like they're not uncomfortable from their varicocele or they're not having issues with fertility, do you still think there's value in fixing a varicocele to improve testosterone?
I don't. And I'll be honest with you. So there's 3 reasons to fix a varicocele. One, in a pediatric. In a kid, if you don't fix the varicocele, the side that has a varicocele, that testicle will atrophy,
Yes.
right? 2 is testis pain, and 3 is infertility.
Yeah.
So when Mark Goldstein first showed the improvement in serum testosterone levels, those numbers were about 85 nanogram per deciliter. I can't justify doing the surgery for 85 nanogram per deciliter.
Yeah.
And remember, it's the grade. So grade 3, the highest grade, tend to see the greatest improvement.
Yes.
So grade 1 has the least improvement, grade 2, grade 3. And if it's bilateral grade 3, you have the most improvement, but it's still about 85, 90 nanogram per deciliter. So it's just hard to justify taking someone back to surgery for that indication.
Yeah. No, I agree with you. I just think I don't want people to start showing up at the urologist
Yeah.
office saying, increase my testosterone and do this surgery that
Right.
has risks.
Right.
You know?
Yeah, and for a marginal benefit.
Right.
Right.
For very minimal benefit. And I think the other thing, obviously, I think the reason that testosterone has gotten so much regulation is because of anabolic steroid use.
Yes.
I've done a deep dive in the literature on anabolics, and there's just so little literature on
Yeah.
it, right? I mean, there's some, but it's really minimal because obviously people taking anabolics are not showing up to sign up for studies, right?
Right.
Because they don't want to get in trouble.
Right.
So in modern day and age, I mean, if you look at the way bodybuilders use anabolics, they if they're, found a smart group of users,
Yeah.
like they're pretty smart about it.
Oh,
They
yeah.
have, they have really tried to hone this in a smart way. But I think let's go over what are the real harms of taking, whether it's exogenous T to supplement muscle gains
Yeah.
or other anabolic steroids. What are the harms of it? And, when should we be worried?
So when you say anabolic steroids, we're looking at things that are not conventionally given. For example,
Correct.
if you look at testosterone enanthate, cypionate, these you can get commercially. We always look at something called the anabolic to androgenic ratio. Like it's a ratio. And most people want high anabolic with low androgenic. So the ones that we get commercially are a 1-to-1, cypionate, enanthate, anabolic to androgenic 1-to-1. The benefits of other anabolics like Anavar, oxandrolone, which is really a 10-to-1 ratio, nandrolone, which is 11-to-1 ratio. So they're giving a lot of anabolic with not a lot of the bad side effects.
Yeah.
And the anabolic mean muscle mass
Correct.
predominantly. So these are FDA approved. They have indications, for example.
Yes.
You know, like nandrolone is FDA approved for anemia in patients with chronic injury disease, right?
Yeah.
And if you have anemia, chronic injury disease, you can give it, but off-label, people use it for bone muscle mass and
Enhancement.
recovery
Yeah.
of injury. Anavar has some indications also for muscle wasting. HIV patients can use it, trying to increase muscle. So I think the problem is that we don't have a lot of training. Like we didn't learn a lot of that.
No.
We don't have a lot of research, like a lot of trials. But, you know, the bodybuilders are really good at this. Like they've really kind of like figured it out. You know, Anavar has some risk. It's hepatotoxicity. So you can have to cycle it. You give them too much, you check LFTs. But I think a lot of it is that, you know, we don't have a lot of training. We haven't done a lot of these kind of treatments. And typically we're in the business of getting patients who are hypogonadal into the eugonadal range to improve their symptoms, energy, muscle mass, libido.
Right.
And I think a lot of the anabolic steroid users are using it to increase muscle mass predominantly.
And I think the hard part is that they start these and now, I mean, there's actually so many young people starting these medications or supplements to do that because there's so much pressure to be like very physically fit and appear a certain way.
yeah.
And they're very easy to access.
Yes.
And I think that the harm there is that we don't really know because as you mentioned, we just don't have the data on a regular healthy person using these medications over long periods of time.
Right.
And I think that's the real danger there. The other thing that comes up is that people get real side effects after stopping.
Oh, yeah. And I see a lot of times when they do stop, what happens is a lot of these patients need to be at a higher level to get symptomatic improvement for some reason. So they say, Doc, you know, you don't understand. When I fall below 1200, I don't feel right.
Yeah.
You know, and I don't know where the data is on that, but that's what I see in my practice.
I see the same
like
thing.
saying like they're using a lot of tea in high doses for a long period of time. You put them at 800, it's not they don't feel it. You know, so something's going on there. So when they stop, also they see a lot of muscle wasting also that can occur as well.
Yeah.
But sometimes we have to stop because of fertility. That's an important point. So sometimes we have to stop because of fertility.
Yeah. Yeah. And then a lot of times they can have sexual side effects.
Yes. And I do think that there's an inverted U. And the inverted U is going with estradiol and testosterone. I think that if the estrogen is too high, I think it can have a negative effect on sexual function and libido.
Yeah.
And I think if this estradiol is too low, we can have a negative effect. We didn't talk about this, but besides libido, when the estrogen falls between 15 and 25 picogram per milliliter, there's a significant increase in bone mineral density going down, osteopenia, osteoporosis. That's the key number.
Yeah.
So when you're treating someone with an anastrozole, and I say, look, just remember that 25. If you're going to put his estradiol at 15, you're putting him at risk.
Yeah.
Right? You're putting him at risk for osteopenia, osteoporosis. And so be very careful. So this inverted U means some people should say, look, you know, my libido is going down. The estradiol could be 112. We bring it back in a little bit. We manage it. They do better. I also think the same is with testosterone. I think if you have super high physiological levels of testosterone, I can see a negative impact sometimes on libido in some patients. So I think the body likes to be in the middle. It just it doesn't like to be low. It likes to be in the middle, centered. And taking someone in one way or the other can have an adverse event.
Yeah, I agree with you. And I think the thing about estrogen is there's a lot of misinformation, right? And people are like, I want as low estrogen as possible. So they start taking an anastrozole. They start taking these blockers, they call them, right? And then they see this loss of libido and they just don't feel themselves. It's not even just libido. They feel changes overall where they just don't feel as great as they used to. You did mention that you rarely use anastrozole. So what would be the indication in your case?
Yes, there's a couple. So I tell patients, don't just throw anastrozole on their preemptively. Patient walks into a clinic, they give them the trifecta. It's testosterone, HCG, and anastrozole. They don't even check the E. They just give it to them. And the reality is that maybe you don't need it. My sweet spot for estrogen is 30 to 50 picogram per milliliter. I think patients do better. Now, it's a little bit higher than most people put it, but I put it there because I think that higher estrogen people have better sexual function and libido. So 30 to 50. So let's say you're at 65. I'm not going to give you Arimidex 1 milligram a day. I'm going to either compound it at 0.25 milligrams or 0.5 and give you just one dose on maybe Monday and maybe later on give you one dose on Thursday. I'm going to slowly manage it to bring it back into the normal range and not shut you down. If I gave you testosterone and your estrogen went up from 30 to 45, great. You never needed the anastrozole in the first place.
Right.
Right? So manage the anastrozole. Don't just throw it on there in the first place. So I think it's very important to realize that if a patient comes in with low T, and they also have a very low estrogen level, be very ready to order a DEXA, because that patient is at a much higher risk than just having a low T alone. It's that E that's your window for the DEXA, and they're going to be at higher risk for osteopenia, osteoporosis.
Yeah, that's super helpful. And I think it's also somewhat expected. If you have low T, there's nothing to convert into estrogen.
Right. That's exactly right. That's exactly right.
And it's going to go up when you give them T.
It's going to go up.
That's a normal expected response.
We expect that. The higher the T, the higher the E, the higher the T, the higher the DHT. So conversion to E is 0.3%, conversion to DHT is 6 to 8%. So if I increase the T, you better believe the E is going to go up. But there's certain things that can take the E away, like obesity. Mm-hmm. Right, so obesity is going to take all that E that I made. Take the T away also. The T is going to convert it into more E.
Yes.
They're going to aromatize as well, so you get even more E.
If you liked that clip from the Rena Malik MD podcast, make sure to check out the full clip right here.